Swayam Prabha. Digital India. Educated India.
Today, we're going to have a quick talk today. So we've got 2 days left. There's a few topics that Sujatha and I think we should try and cover. So the first one today is looking a little bit more at innovation and systems. So yesterday we very much focused in on products, right? How do we innovate in that product category? But what you'll find in a minute is that there's a lot of innovation in that area, and actually you need to begin to look at that wider ecosystem. So this was a paper we did, a review of innovation strategies and processes to improve access to assistive technology. So we wanted to, Sujatha is the last author of that paper, and I'm the first author of the paper, and it was one of those papers we did during COVID, wasn't it? And actually, it was one of the meetings each week I really looked forward to, because during COVID, it's quite isolating, and then once a week, myself and Sujatha and somebody maybe from MIT and somebody from Southampton, and we all just got on this call and we were discussing innovation strategies. And I think the call was only ever meant to last for 1 hour, and like 2.5 hours later we were still talking and talking and talking. So it was really enjoyable to do, actually, and I say that from somebody who, if I'm honest, I'm not a big literature review person. I don't like doing systematic reviews. I find them, I get a bit bored once I realise where they're going, and so I find it hard. But this one was good fun. So we were working with the WHO definitions, which you'll know well at this stage, but assistive technology being that umbrella term for the combination of the products, but also the services needed to ensure safe assessment, distribution and use of assistive products. And then knowing that an assistive product could be any digital or physical device, which is external to the human body, whose primary purpose is to maintain or improve an individual's functioning and independence and thereby promote their well-being. Right? So those were the definitions we were working off of. And our objectives were 3, and our methods were 2. The objectives were to identify and to describe strategies and processes for product provision and supply innovations. Then also to recommend effective strategies and methods to stimulate this innovation within that area, and to describe principles of innovation that improve access to assistive technology. Now, this paper wasn't something that myself and Sujatha sat down one day and went, oh, shall we have a look at this area? This seems really exciting. It was actually something that the WHO came to me as a collaborating centre and said, we're about to write a global report and we don't have enough evidence on innovation, so we need to know what's happening. So that's why we convened a group of people to run this. And then we wanted to describe principles of innovation that improve access to assistive technology. And the methods were a systematic review. It ended up being more of a scoping review. It's very systematic in the methods, but we didn't go into the quality of each paper. We simply ranked if the paper did something or didn't do something. We didn't dive into that quality level. Oops, started taking something else. And then semi-structured interviews and thematic analysis. So the reason that we did some semi-structured interviews and thematic analysis was 2 reasons, really. The first was once we started looking at some of the papers, we realised that we would be able to answer this one, strategies and processes, but underneath that effective bit, you have to get to know the why. You need to not everything's presented in a paper, right? And also we realised that as we went through these papers, Sujatha and I would be talking and we're thinking, hang on, what about ProsFit? They're a good innovation company in prosthetics. They don't have academic papers. Does that make sense? They're just innovating in prosthetics. And then there's somebody else over here innovating, like Neomotion might actually have some papers, but if they didn't come out of an academic institution, or if they were, say, a master's project that then they spun out, if they didn't stay incubated in that academic setting, they're just 2 people desperately trying to get a product to market. They don't have time to write academic papers. So we put a call out for case studies, and we went through the WHO GATE network, and we also sent it through the innovation network that we have at UCL, and we just tried to get other case studies. But then we also thought we'd pick 2 areas and we'd try and do a deep dive in those areas and see what the innovators in that space were saying were barriers, challenges, the things that had happened. So one of the frameworks, we looked for a framework at the beginning, and this is Mac McLaughlin. I supported this paper, but in truth, I'm not even sure really my name deserved to be on the paper. I helped with about 2 paragraphs and a couple of conversations, and Max reckoned that was very influential. When I saw my name on the paper, I was like, very generous of you, but I'm not sure. I really did the hard work on this one compared to the innovation strategies paper. But this paper Mac and team, which apparently includes me, is we have the systems level. So within a system, you might have the individual that, you met people who are wheelchair users. You've got that level of interaction. Okay, so here you've got the individual level where you just got the person. So if in a minimally functioning market at an individual level, the person has difficulty matching assistive products to an individual's needs. So they might, I was talking to somebody just last night who's been doing some work in Nigeria. And in Nigeria, the biggest problem is that the informal market basically provides wheelchairs to people. People sell wheelchairs to one another as their needs change. And so they've maybe only got a choice of one wheelchair, which is that person's wheelchair they're giving away. And as you saw yesterday, if you sit in the wrong size wheelchair, it's almost useless, right? So in a really poorly functioning market space where there's no real product choice, you've got to that point where there's nothing. You've just got to take anything, and it may or may not be a good fit. So there's definitely no person-centered services because there's only just what you can get. And generally, they're too expensive for people. So it generally is that only rich people can get them. When you move into a more moderately functioning marketplace, you have limited choice of products or services, a patchwork of poorly integrated service provisions, and few pricing alternatives and funding alternatives. So it might be that I've been to some countries where if you're wealthy, yes, there's a selection. There's like one shop in the country that stocks 10 great types of wheelchairs or can import for you. But if you're living over there and you have a little bit less money, then your option is not, there isn't that option for you. In an optimally functioning market, and I honestly believe that this optimally functioning market, there's only two places in the world, in my opinion, that this really exists, and that's in Norway and Sweden. I'm sure the United States of America, I'm sure the UK, I'm even sure Canada would like to say that they'd be in there. And I think the US and Canada are probably there. To an extent, the UK is, but it's still a bit patchworky. We did a recent review in England of services. We've just published a report, and it was the government, the Cabinet Office, asked us to do this report. And in some places, people are waiting 2 years for an electric wheelchair in England. So it's not like we've got this optimally functioning system. I mean, yes, I can get glasses as soon as I need them. Yes, if I had a spinal injury in the morning, if I had a road traffic accident in the UK, somebody would spend £250,000 operating on me and it wouldn't cost me anything. I'd be fully rehabilitated. I would be given a choice of wheelchairs to choose from. I'd have a perfect service. If I was an 80-year-old who had a stroke, I'd probably just be given any old wheelchair as I left the hospital, right? So it's not yet optimal. It's a bit, in some places it's brilliant, and in some services it's brilliant, but in other places it's still that patchwork idea. And the reason the patchwork stuff comes up is because of that right at the very beginning, when we talked about the medical model of disability, we have to remember that most things did come from there or came from education settings. So it either came from physiotherapists and rehabilitation therapists or orthopedic surgeons, or over here we might have the odometry people, and over here we have the ophthalmologists. And the ophthalmologists don't often speak to the audiologists, who don't often speak to the orthopedic surgeons, because they're all very busy in their own culture, in their own world. And so assistive technology sort of grown up in these places. But if you're a person who needs glasses and a hearing aid and a wheelchair, and you also need some rehab services, you're probably having to be you're the person that has to manage every single one of those hospital relations, which is genuinely exhausting, right? Now, if you move up into this meso level, what does it mean at a meso level? A meso level is a sort of service provider. Now, that could in the UK be the National Health Service. Could here be, what's the equivalent of National Health Service in India? Indian, anybody, if you go to like the Ames Hospital, you don't pay that much. It's like the government hospital system. So that would be a service provider, but then you'd also in India have a private service medical provider. And the same as the UK, you might have Bupa, that's a private medical insurance provider. And that level of provider, if they are working in a minimally functioning market, they have difficulties regarding design, production, assessment, provision, or maintenance of assistive technology. So they might want to provide all of these things, but maybe they can't import or export. Maybe they can't get the spare parts. Maybe there's not enough trained personnel within the country to be able to deploy these things. Whereas when you go into a moderately functioning market, you begin to find that some of those have matured and are working very well. So you get these market niches that are working really well, but it's not a fully integrated system. Whereas if you go to a optionally functioning market, there's like interoperability. People are maybe having one caseworker across all of the services. You get inter-organizational activities where they might have one place, for example, where you can come. I remember going in Japan was the first time I ever saw a place in a hospital where you walked in, and it was a charity type thing attached to the hospital, and it was your NCAT centre by 6 times, 7 times the space, and it just had loads of assistive technologies, different beds for elderly people, different walking frames. You could go in and try all of the different things that you want. And even at our summit the other day, somebody was talking about their roller, and she's a young woman, she's got this purple roller, and she said the best thing that happened to her was she could go to a shop where they had hundreds, and she could try the one that really worked for her, you know, and lots of them didn't work for her for various reasons. So you get that interoperability. At a national or international level, when the minimally functioning market, you've got difficulties in national procurement, little product or service innovation, few disruptive initiatives, and few feedback loops. So I'm not going to name countries, but I've been in countries, for example, where there is a budget for personnel in hospitals, but there's no budget. The year-on-year budget for materials is signed off year on year, but the staff are permanent. So you'll go to a prosthetics clinic and they have 5 prosthetists, but no materials. And you're able, what are they meant to do? So they're literally like getting bits of leather, trying to make things. They're getting old devices, they're trying to retrofit them. Actually, they are being incredibly innovative, but they're just being paid basically to see patients that they can't help, which is very demoralizing. In a moderately functioning market, you get siloed supply and demand, restricted supply and demand of products or services. So you might have, for example, one thing that ourselves at GDI Hub, the 80-20-30 programme, which is funded by UK Aid, and at scale, the Global Partnership on Assistive Technology, one thing that we're working together on at the moment is trying to get an international agreement between at least a few countries to completely get rid of levies and taxes on assistive technologies, even if it's only a limited number. So for example, we've got innovators in Kenya, and they've got a good product. At the moment, realistically, they can only, if they've manufactured in Kenya, which of course the Kenyan government wants them to do, in the same way as India would want you to manufacture your products in India, but the minute you wanted to export that to Bangladesh, or I won't say export it to Pakistan, that might be even more difficult, but if you want to export it to Bangladesh, you're going to end up with probably months of delays in getting your product to market, right? So if we want to get stuff into a country, we often ask good friends like the ICRC or Humanitarian Inclusion, because they'll have booked a container to go, and they'll have an inventory, and if they have a little bit of space, could you fit these 5 wheelchairs on there just for this test? Adding that to an inventory of a known supplier is much easier. But if you're just random innovator, how are you going to know how to do that? It's massive amounts of paperwork, and then also it will get stuck because every bit of bureaucracy gets stuck. So you have this problem, and at an international level, you'll have that problem. You'll just get stuff stuck in ports or customs, might not even be your country, nothing you can do about it, but you're importing and it's got stuck somewhere. Or it's been sent back to the United States, you know, and now you're trying to get it back in. But when you get to an optionally functioning market, you have universal coverage of needs at the national level. Opportunities are addressed for the overall population subgroups. Now, my example here is always Norway. Now, I know that Sweden does this same model, but I've never been to Sweden to see it, and I was invited to see the one in Norway, so I know it better. In Norway, if you say you're Puma, you have an accident, you need a wheelchair. In Norway, let's say I'm a skier, and I'm skiing, and I fall, and I have a spinal injury. Once I'm rehabilitated, because they follow a human rights model, they believe it's my human rights. What is it? What are the activities I would like to do? Well, I would like to be able to go to work. I'd like to remain living in the house with my family, and I want to still be able to ski. Fine. Here's 3 wheelchairs. Here's one for outdoor use that can be plugged in outside so you'll be able to travel. Here's one for your indoor use, and here's one for you to go skiing. I don't own any of those wheelchairs, but they're mine for as long as I want them. They get serviced by the government for as long as I want them. And then the minute I decide, you know what, I'm not skiing anymore. I'm getting old, I don't want to ski anymore. I just give that wheelchair back. They reservice 60%. So So 60% of their assistive technology, once it's given back, it gets decontaminated, any parts that were worn or torn get replaced, and then it's a completely refurbished wheelchair for the next person who wants to go skiing, right? Now, obviously, things like cushions, if you've been using cushions for a long time, they have to be recycled. It's very difficult to transfer things that maybe have had wear and tear that you just can't use. So in that system, I just go in, and if now I'm getting older, I'm not going to go skiing anymore, but actually I'm losing my hearing, that's fine. Get some hearing aids. Now, hearing aids and glasses are the only bits that are separate. They're sort of still on the high street. They've evolved out of the high street. But if, for example, I'm deaf and I want lights, switches, like if the doorbell goes, I'd like a light to flash in my room, then the same place, I go to one place, and that person will assess me for all of my needs, and if necessary, so it's sort of done on a regional level, and each region has one of these hubs, and then it has spokes. And it just works. It works seamlessly. Now, it costs a lot of money, but in their view, the money isn't important because they're following a human rights model. And actually, recent work is beginning to show that because all of the population continues to work, and because we don't have the care burden, actually it's not costing a lot of money at all. It's just, it takes a long time to calculate the benefits of a program like that. So that's where everybody wants to get to. And yeah, as I say, in my humble opinion, Norway is one of the few places that's done that. We wrote a paper actually recently, which I can share tomorrow, where we compare that and compare the human rights model within this macroeconomics part. Now, digital assistive technology, despite this is one of the product narratives that we wrote in digital. We did one on prosthetics, one on hearing aids, one on glasses, one on wheelchairs, I missed one. So there's loads out there. There's loads of explanations as to why markets are failing. But when you look inside these documents, one of the things that's written time and time again is that one of the biggest problems with the market failure is that they're poorly understood. Assistive products are poorly understood, and they're often in academic and in policy terms, they're always in a health and social perspective. Everybody's always back to health and social, maybe a bit education, but you don't hear people talking about, for example, wheelchairs to go skiing, or Puma wants to become a dancer. Like, what wheelchair would he need to be a dancer? Because I think he'd be a great dancer. But he might not want to be a dancer. But there might be things that you want to do, but it will just be categorised under these very medical places. Whereas I don't think you think of yourself in a medical way, do you? Like, you just don't think of yourself as a series of like medical components. Like, you just are a full person. So we don't really have a coherent group when we go to talk to people. And the recent product narratives demonstrated that the market dynamics can be different across different categories of products and individual markets. So we've got this problem where when you try to scale assistive technology totally, in glasses, for example, you probably would find it quite strange to think that you can't get glasses. And yet I know of a study in India of people that were retiring early from picking tea leaves because they assumed they were going blind, and they had no idea that they weren't going blind. It was a massive study with Unilever to roll out screening for glasses and give glasses, and all of a sudden people are not blind, right? So, but people thought that they were going blind, and that's fine. But you still can't pick these up in some places. Like, sometimes when I'm travelling, I'll always travel with a second pair because I know that in that country it's going to be more difficult if my glasses ever did get broken. So there's this unique feature, and then there's this overarching problem. So you've got this overarching problem that is still health, and then the minute you get into health, people think about health technology assessments or cost-benefit analysis, and then you get to that problem where most of those are done on things like QALYs and DALYs, so quality of life adjusted years. And so do you know what QALYs and DALYs are? No? So it's when you ask somebody, like I ask you, so somebody will do a survey and they'll say to you, how, if you had to live with cancer from the age of 40, what impact do you think that would have on your life? And they sort of trade it off in terms of years. So they'll end up with these calculations that say, having done this massive population survey, we think that living with a stroke, it sort of is equivalent to losing, you've got 10 years of 80% life type thing, whereas living with cancer, you've got 2 years of only 10% life because chemo's so bad. But then if you survive, you might go back up to 100%, but at the middle of that, you've got 20% will die. And so they add that in. So everything's related to sort of a stroke is worth 5 years to cancer, which is worth 3 years to something else. And it's all done on mortality at the top level. So if you've got an intervention like malaria things, it's always like, well, how many lives will it save and how many months of life will it improve? Now you come to an assistive technology and it's being assessed against that. So if you go through the medical route, you'll have something where you say, well, I've got a new angioplasty catheter. It will save X more million lives and it will improve the lives of X more million, so therefore people will live quality lives of X number of years. Brilliant. They're all very excited. You go in and you say, well, I want to improve assistive technologies. Well, I'm sure it does if you have a wheelchair and you have skills and you have the confidence to go everywhere. I'm sure that means you will live a longer life, right? Your cardiovascular system will be better, you will be less depressed, you'll probably get less overweight. There's loads of reasons, but they're all sort of indirect. They're not immediate to answer. So it becomes very difficult when you're arguing in these policy terms for people to put a budget against the different assistive technologies. And then once they do decide to put something into assistive technology, they don't know where to put it. They're just like, is it wheelchairs? Is it hearing aids? Is it glasses? Is it prosthetics? Is it audiology screening? Like where to start? So one of the ideas here was just to take that landscape approach. So we had done those landscaping approaches, and then beyond that, once we'd found all these system errors, which were reported in the product narratives, we thought, well, innovation does happen. It's defined by the OECD, and we adapted their definitions for the paper. So AT innovation, we said, was the implementation of a new or improved product or process, or a combination of that creates a significantly different product or process that allows for new assistive products or services to be provided to potential AT users or brought into use by AT users. Now, it doesn't say there that any of the products or systems actually have to be successful. It says it has to be new and it has to be tested. And that's the big thing about an innovation, is you can fail and still have been innovative. Like the actual end product could be innovative, but provided what you're trialing is new in either product or service, and you test it. So to invent it would be just to make it. To innovate would be then to test it. Okay? So then the product innovation is an assistive device that is new or significantly improved, that includes significant improvements in technical specifications, components and materials, or software in the device, or user-friendliness or other functional characteristics. So user-friendliness is quite important here, because sometimes, as you saw yesterday, you're trying to tell the difference between two wheelchairs, for example. If you can improve that user experience of the wheelchair, you saw yesterday it's a significant difference, even though you might say the wheel has very similar componentry, the actual outcome is different. Supply innovation was if a new or significantly improved process that includes significant changes in delivery from manufacturing to service providers. So are you producing it differently, or are you getting it to people differently? And then provision was a new or significant improvement in one or more of the processes in the provision system, and any process and between the assessment of needs to supply. So the middle one, in terms of supply, is more about that manufacturing process and actually getting it to people, whereas provision also includes how do you know somebody needs it? So screening innovations, for example, like how would you know who to give innovations to? So I'll show an example later of an app that we've developed with London School, where one community healthcare worker can screen for hearing loss, vision loss, and mobility impairment all in one go, and then can triage people. And so that means that people don't have to travel to hospitals for individual things and those individual places. So it means that you're getting a streamline of who needs to go to which service, rather than people going to services that either they don't need to go to. So as an example, you need to go and get high street pair of glasses. You don't really need to go to a hospital for that, but yet people go to a hospital first only to find out that they need some glasses. Does that make sense? Or they lose their hearing and they don't actually know where to go. So it streamlines that process. So when we did all this, we interviewed, as I said, two sets of people. So it was eyeglasses and prosthetics. Now the reason we chose eyeglasses and prosthetics was partly because of a different bit of work that I'm going to talk about later, which Ben and I were doing, which was on digital manufacturing and prosthetics. Now, I don't know, some of you wear glasses. When you got glasses, did you put your face into a machine and it just did stuff? Yeah, how many people did that? I did that. Yeah. Previously, some of you might remember, some of us might remember, previously a person would put a pair of glasses on that would have little slats in, and they would put lenses in. They still do that sometimes. They still do that sometimes, yeah. And I've had both, actually. So I went to a local optician in London about 7 years ago, and he did that. Whereas normally if I go onto the high street to Specsavers, I literally just sit there. They shoot stuff in my eyes, they tell me to follow some things, and then they produce a pair of glasses. Now, one of those is totally digital, right? It's assessing everything digitally, and one of them is quite manual, right? Now, in the prosthetics world, it's gone. Like, people are happy with to use the digital in ophthalmology. And ophthalmologists are happy. I've got to take the timers off these slides. Ophthalmologists are happy with those. They're happy to provide glasses in that way. Now, when you speak to prosthethists, to fit a prosthetic is a craft, right? You've got to mould against a stump. You've got to really think about the distribution of forces. You've got to, the way that you're going to run that cast, the way that you'll do those final adaptations. You might scrape a little bit off here. You get people to walk. You analyse their gait. You think about it. You do a bit more. Right now, people who've done that all their lives, some people are very resistant to moving to digital. Very. They do not believe that level of crafts work can be automated. And so we were thinking, well, one sector has wholeheartedly seems to love the digital, and one seems to be very resistant to it. They don't seem to want to when we talk about using scanning, or when you use CAD CAM to make some of the components, or if you want to 3D print the components, you can literally be shouted at. So I presented once at ISPO, and at the end I've told Sujatha this, I went for dinner, I came back into the conference hall, I'm trying to go to my room, and a man stood in front of me, blocking my way to the stairs, and just was shouting at me. I was like, okay, you don't know what you're talking about. Digital manufacturing's not the way. I'm a prosthetist. I've been a prosthetist. You're not a prosthetist. You don't know what you're talking about. Who are you? I'm like, but that's a really interesting perspective. I'd like to get to my room, please. Would you mind just stepping aside? I'd like to get to... And it's actually a wheelchair user came over and saved me. David Constantine wheeled over and went, I think you should just let Catherine go to bed. I think she just wants to go to bed. I don't think you should be shouting at her. And the next day, I don't think he really realised he was shouting at me. I think he was just so... Well, partly he'd had a few drinks, but the other reason was that he was so passionate that people like me, these technologists, were going to destroy people's lives. You know, and he really believed that. Like he really did believe it. And so it's worth realising that there's that level of passion, because if you're trying to innovate into that space, you can't do it without the prosthetist being on your side, right? It's very difficult. Like if the clinicians are against you, you're not going to get there. Like when I worked in Medtronic, we spent a lot of time being flown to Dublin to stay in a hospital, working, watching cardiovascular surgeons and talking to them and listening to them, because we wanted them to make sure they knew we were listening. And then when we'd be able to go back with a new product, we could show them how a bit of information they gave us had translated into a new product, because they want to have confidence in the product too. So we wanted to test these two things. So we ended up clustering overall the thematic analysis into open innovation and radical and disruptive innovation. So the ones that are red, we also did digital, just because digital was up and coming just as its own thing. So we had these 3 sets of interviews. I always forget about them because the other two, they were less controversial. So across the board, well, for prosthetics, there was this idea that digital transformation could enable things. So it was quite funny because we went to talk to people, even if they were a bit angry about how it was currently being produced, they would say, you know, it can work. Digital transformation can work, but nobody's proven to me it can work. But I can see that, for example, scanning stumps could be useful, but I need evidence for this, and especially 3D printing. They thought, 3D printing, fine, but prove to me it works. Nobody's proven it. In digital, in open innovation, they thought that if you want to get products adopted, so things like screen readers or augmented communication aids or anything, or even just mobile phones as an assistive technology, the biggest barrier was actually having somebody within an organisation to champion that, just to get people to want to, because the technologies actually, there were no supply problems really. It was more just about getting people to understand the benefits. Also customising the service delivery, so just not giving a one-size-fits-all, but actually having adaptability within the software. Making sure that it's interoperable. So when we go on after the break to ALS, designing for people with ALS, you'll see they've got a lot of assistive tech, right? They might have to, and their function changes. You'll see that they use lots of different assistive techs, maybe month on month. And so if they don't all plug and play into the main thing, that's very annoying. Like if all of a sudden I've been using one device to communicate, but I can no longer use my hands, and now I've got to use an eye tracker and the eye tracker doesn't work with it, and I now have to get used to an entire new device, that's very frustrating. Standardization and universal design to allow bespoke service. So they were thinking that oftentimes the service component, and this is the case with ProsFit actually, the service component is locked to the manufacturer. So for example, ProsFit have signed a deal with Hewlett-Packard, and Hewlett-Packard will do the printing for them. But that means that if a country buys into that, they're buying into one service provider, which is Hewlett-Packard. Does that make sense? And so it will be very difficult after a while to innovate in that system because you'll have bought the infrastructure of one provider. And it's not anything against Hewlett-Packard. It's just you don't want that one, you just don't want that monopoly in your innovation system because monopolies don't drive innovation. And so therefore having an open market development and sort of spread of support for people would be really useful. In eyeglasses, leveraging research and development activities. So people spoke about how once that happened, it worked really well. So PEAK is an example where it was a London School of Hygiene and Tropical Medicine. It's using a camera to test your eyesight on your mobile phone. And so the tests that we've done in those ophthalmologist eyeglasses clinics, you can do in the field just using a phone. And that was research and development, but it had a translation pathway into the market. And the other thing that with eyeglasses, the reason they said everything worked so well was because there was quite a lot of strategic networking and partnerships and collaborations. So it's a little bit like, Sujatha, your grid model, but those grid models had sort of established in a certain area, and they'd done so much together that they knew how to take anything that came in and how to grow. The things that were the barriers, we only found barriers to innovation whenever we spoke, and we tried to get barriers to innovation out from everybody, but you'll see that all the barriers are red. That means they all come from prosthetists. Right? The people in the eyeglasses sector and the digital sector, they said, oh, there's no real barriers, it's just, you get on with it. But in prosthetics, it was product life cycle, aftercare and long-term provision. And you can see why that would be a problem there and maybe not digital. You can push a software update. Eyeglasses, they're not that difficult to replace. The infrastructure is not that hard. But in prosthetics, when something ends, you've got to go right the way back to that cycle. And there's a lack of data and standards in prosthetics. So it makes it more difficult for innovation to occur because how do you hit the standards? The reasons glasses work so well is because it's quite easy to know when you've hit those standards. In terms of radical and disruptive innovations, again, they thought digital was really helping to do some leapfrogging, whether it be anywhere in prosthetics, but digital scanning, digital CAD/CAM manufacturing, even 3D printing, they're all quite radical and disruptive, and they're an enabler. Innovating within a highly complex ecosystem. So some people, what's happening is that the prosthetic companies, like the wheelchair companies, the major ones, are not in low and middle income countries. So if you take Ottobock, which is the major prosthetics company, they have a single person in Kenya who's a sales rep. Now that's it. So that means that a lot of innovation's happening locally in prosthetics because there's not a market competitor. So there's a lot happening there. So in those, and we were calling those, they called them complex ecosystems because they weren't highly structured in the way that higher income countries are. Innovating, so for eyeglasses, a lot of innovation was happening in uncontested market spaces. So for example, in Kenya, there was a company doing, they had a device that you fit here and you could quickly check your eyeglasses, but it could come to you and you put it on your head and it's like that switching machine, but it was manual. And so because there wasn't a rollout nationally in Kenya of as many eyeglasses places as there was, say, in London or in India, they were going to companies that needed this. So as an example, they screened the haulage companies, one of the haulage companies, the big trucks. They screened them, and I forget the figures, so I forget, it was just a conversation over a cup of coffee, but it was something like 70% of the drivers couldn't see more than 5 meters ahead of them, and 20% couldn't see more than a meter ahead of them. So once they produced that evidence to the board of that company, of course the board went, well, obviously our accident numbers are going to decrease if we can give them glasses. So they began to build glasses into the employment benefits package. So there's innovation happening there in spaces that maybe classic clinicians wouldn't go. Closing the supply chain gap, there's people over here now, or anywhere you go, there's now people that will deliver you things for nothing. You know, there's always an app, isn't there? I need some groceries, I need a pen or something, and somebody will come on a two-wheeler and deliver it to you. So can we get our spare parts into there? Does that make sense? Can we get them to be closing that supply chain gap? Technology aided enhancement of clinical care provision. So just trying to cut down the amount of time because you can assess very quickly. That's been quite radical. And disruptive products. So there are products which are now snaps. So snap lenses, which means that the frames remain the same no matter what. It even means you could share glasses. Not that we'd recommend that, but it does mean that in a family you could. In digital, the enabler was contextual adaptability and awareness. The most radical thing was if the thing could change relative to where you were. So especially for blind and partially sighted people, switching the audio down if you're in a hospital, clinic maybe, turning it up when you go up, but automating that space. And in terms of barriers, again, only in prosthetics, there's barriers to scaling innovation. That really comes from the lack of data and standards, but the reason these radical disruptions don't happen is because you can never prove that they work. Overcoming resistance to change. A lot of innovators said there's just a lot of cultural resistance to change and funding constraints. And I think one of the reasons there is so much resistance in the prosthetics world is that lack mentality. If you work somewhere in a sector where you're constantly having to fight, you're constantly overworked, you constantly don't have the resources you need, it's very difficult to be in a generous mindset, especially when over there glasses are getting a fortune and cancer treatments getting a fortune, and you and your two friends or colleagues are just desperately trying to get prosthetics to people, and you're knackered and you've worked 14 hours, and then some innovator comes in and goes, I've got a digital solution that's going to transform how you do everything. You're just like, oh, go away. Yet another. Yeah. So you can understand that the psychology of stuff sort of it intertwines into it just not working. So then in the systematic review, we looked at 3,127 papers, joyfully. So the reds on the left, these are the papers, and then these are the case studies. So the AT 2030 database, we already had 45 case studies of innovation that we had collected. We put out a first call, we got an extra 6. A second call, we got an additional 16. And then there were some interviews that had been recorded, say, for certain television programs or things like that, or publications, like magazine publications that wouldn't make a systematic review, but we included them because they were case studies of innovations. Of the case studies, only 74 were eligible, so we ended up including 72 in the overall review. 2 were dropped in that final eligibility criteria. Sorry, I keep forgetting to do those. And in the papers, after duplicates, we had 2,126, and that went down to 91 in the end when we looked through everything. And that, I can go into why we dropped so many, but mostly it's because they either had invented but not innovated, so they'd not done any testing, or they were, even though they came up in the search terms, they were just sort of theoretical papers, theoretical discussions around innovation ecosystems, or review papers. So these were the results. So we had 3 categories. We had case studies, which were of assistive technology. The light, the pink in the middle, is adjacent innovation. So one of the reasons we had so many papers initially, and then it narrowed down, was when we first did the systematic review, if we only had assistive technology keywords in, there really wasn't very many papers. And so we thought, well, there must be other areas of innovation that we could learn from. There's some medical device technologies, some educational device technologies. They might not have called them assistive technologies, but actually the principles of them could be adopted. So we had this category of what we called adjacent innovation, and then we had core AT innovation. And so you can see here that so if you look at product, there's, in terms of provision here and here, so in terms of product, nearly 50 to 75% of the case studies were all about the product. right? Loads and loads of innovation around products. Brilliant. Then coming below that, you had provision. So nearly 40% of the innovations were around the provision system. But supply, there was nothing. Like so few case studies on supply. And actually, if you took away the yellow bar, you've got only 10% of the others are actually on that supply side. So how do we actually get it to people? New financing models, for example. So people are getting products, then some of those companies are figuring out how they're going to manufacture them and maybe supply them to places. But then, and we're seeing this every time, all the innovators. So we've supported 48 innovators in Kenya and probably another 20 to 30 around the world. And each time, 90% of them had a product. And then the next, they got it, and they've got that working, and they got CE marking, and they did the ISO test, everything's brilliant. And it was all great user fit, user design, everyone's very happy. And then they suddenly went, oh my God, now I've got to, I can only make 10 of these. So now I've got to find out how I'm going to manufacture it at some sort of scale. That was the next problem. And then, once they'd sort of figured that out, people weren't buying it because nobody could afford it. So then they often just go bust at that point because they haven't thought about how people are going to get it at the beginning. And that might have changed how you'd have designed the product, right? You might have made different design choices if you'd known how much people could afford to pay, like if you'd had that as a design constraint. So this is my favourite graph. I made this graph. I love graphs. So you can tell it was COVID and I had lots of evenings to myself. There's about 100 versions of this. What it's meant to mean, and it might just be one of those graphs that only I love, everybody else just gets confused. But the x-axis is going back to that smart matrix. You've got minimally functioning market, moderately functioning market, and optimally functioning market. Can you see along here? And up here you've got the micros, that would be the individual. Here you've got like a factory, and here, oops, I always keep hitting that button. And here, this is a factory. No, it's not. Can't use a pen. Let's try again. No, I give up. Okay, so that's a factory, and then that's a country. Imagine, use your imagination. It's like it's not connected. Anyway, okay, I think it's just lagging. I think that's the problem. I'm going to put the pen. Okay, so basically you're going from down here, minimally functioning market. This is a recording that I made before. I should have taken it off. So follow this pen. So down here, there's a lot of innovations in terms of products. In terms of product, there's a lot of innovation here. Some innovations try to move. This pen has gone mad, so I'm trying to use my pen. Can I stand over here? If you go, can you see the bottom row, micro? You see the bottom micro row? Some innovations are just in products in that minimally functioning market. Okay, let's try again. Hang on. I think there might just be a discussion. I think two things are happening. The pen's playing up and that's playing up. Okay, so if you start down here, you've got innovations that are just in minimally functioning markets. So in low and middle income countries, often really poor settings, people are developing a new product. Great. Some people, these are P stand for products and C stand for case studies, and the numbers mean that you can look them up in our database so that you can see which one they mean. So if you wanted to go and innovate in a moderate, you wanted to develop some innovation that goes from minimally functioning market and is actually almost like a service provision model to try and improve that service to bring it into a moderately functioning market, then you could go and look up the products 4, 5, 84 and C 11, 14, 27 and 56, and they would show you case studies that go across those two boundaries. Over here, for example, these are innovations that are just in optimally functioning markets. Here you've got, these are innovations that operate at the meso level, and these are innovations that operate at a macro level. Now, P89 here starts down here at the micro level and shows that it can, it looks at developing in a minimally functioning market, moves quite quickly to moderately functioning market of a development. It shows the development of that moderately functioning market. Actually shows that the device could also work in a optimally functioning market because it's a good enough design that would enter there, but also begins to look at how that would be supplied at a meso level, so how it could be supplied in a service delivery context, and then also shows how, or mentions how it could be scaled nationally or internationally. That is one of your papers, Sujatha. You probably didn't know that, did you? But it is one of your, I think it's the standing wheelchair one. But in the entire paper, it goes right the way from concept. It's the grid model paper. which has all these examples in it, but it sort of demonstrates all of these pathways. You could start from a very low setting, but most of them, you'll see that most of them are happening here at this like meso and macro level of innovation. So we're having, but nothing's really translating through. Everything's just staying in its own bubble, mostly. It's staying in its own bubble. So, and what you'll find generally is that as you go up here, the innovations can be innovations that hit their countrywide innovation, that they're trying to do something, but they just don't scale particularly well. So our findings were that because of this fragmentation everywhere, we should begin to think about what's called mission-led innovation, which is something that is more of a government level, at that top level. That, you know, for example, you have Make in India, right? Or Startup India, or, you know, Keep India Clean campaigns. They're like campaigns that come from the top, but they sort of percolate everything, every government ministry, and then every college, and everybody's trying to see how they can. There will be budgets attached to it as well, but they're trying to show how they link back to it. So if you had a mission which was, we're going to be disability inclusive India, for example, then everybody would have to start to think healthcare, innovative, everything would have to start to think that way, and that would shift the mindset, right? And you could call it something else, inclusive India or something. It could be broader than disability. Disability could be a component of it, but it would have to be there that's quite visible, that would be top down. We also just need to explain AT better, and I must say that at scale are doing a good job of this. They're going around the world, talking to ministries and really explaining this. This is like their job at the moment, just to get that systems level working better. Begin to create systems for open innovation, so get people talking so that we don't end up with that problem where we just have products. But if those innovators were always talking to manufacturers and the healthcare suppliers, and they had like a monthly meetup even, they would never make those mistakes. That level of openness would open up new activities. We need more active stakeholder involvement, and by that we really mean NGOs and DPOs and disabled people, or people with disabilities. So you're often finding, as you found, Sujatha, even in your standing wheelchair, that you tested it. Also healthcare professionals, yeah. But your standing wheelchair, you hadn't thought that the knees would fall out until you had somebody whose legs, you know, didn't independently move. So having those people, but if you didn't have active stakeholder involvement, you'd never have figured that. You could have gone all the way to market thinking it would have passed every single test, and it could have gone to market, and then it would have failed miserably, right? So that active stakeholder involvement, and also I'm sure she showed earlier, you were in hospitals with clinicians getting their feedback. So you weren't then, you need their feedback, but you also need their backing. Because they're the person, you're going to go and see that clinician, so you need that clinician to help signpost you to the right information and the right wheelchair provision, or even be the ones that are providing it. We need the system strengthening is just always needed, and by system strengthening we mean policies, but behind policies they need budgets, behind budgets you need trained personnel, behind trained personnel you need product and provision systems that work. You might even have payment systems. So I know India does everything now via mobile payments, but you could have a mobile payment system for assistive technology, for example, that maybe is pay-as-you-go nationally. That would be an amazing innovation. That would mean that you could even start saving now towards your future AT. That could be something that you could sign up to say, I'm going to put, I don't know, so many rupees aside each month, and it's going, and then maybe that money could be matched by the government at a certain point. And then that would be a way of financing things, you know. So there could be different models of system strengthening, and that finance and expertise, like how we get better evidence for how assistive technologies work, and begin to push back a little bit on this number of years saved, number of lives saved, but have a slightly different model of how we finance and support assistive technology. Honestly, I think the Norway model is the way, you know, human rights-based model, and then we just think about how we finance such a model, I think, is what we should be doing. So in terms of mission-led, we go on to say that bold missions are proven mechanisms to increase innovation within countries. The classic example that's always given, and there's a woman in UCL called Mariana Mazzucato. She's Italian, but grew up, I think, in the States. But she has now written a number of books on the entrepreneurial state. She's got a series of books. Every time you meet her, she's entertaining some prime minister or other. And if you follow her on Twitter or something, she just meets prime minister after, you know, and all the time she's helping them set these missions, right? And the classic mission that she talks about in her first book was going to the moon, right? I'm sure it might have been the same here in India recently, but in the States, you know, there's that classic example that someone asks the guy who's sweeping the floor, what are you doing? And he says, I'm helping to get a man on the moon, right? Everybody thought they were working towards one goal. It didn't matter what you were doing in that system, you were helping to get this rocket into space and safely land a man on the moon. That was your job. And that mission activity led to loads of things, right? It led to loads of innovation. So yes, in one instance, you've got a rocket up into space, but a lot of that technology then infiltrated lots of other things, and that bold mission just got everybody behind something. So how do we embed AT? Like, we've gone backwards and forwards on this. I don't think assistive technology can be its own mission, partly because it's a means to an end. It's a means to human rights. It's a means to good health. It's a means to good education. So somehow it has to be infused into everything, and it has to be sort of unlocked as a classic enabler. Like, you just wouldn't think, like in education, for example, you wouldn't say, well, we won't have any teachers, or we're not going to have any desks. So when kids go to school, we're not going to have schools. Like, it needs to be that basic an infrastructure that we just think, well, obviously we're all going to live older, obviously we're going to need these technologies, obviously it should be there for us. So for example, you might be tackling an ageing society grand challenge, because that often comes up now, and you need to make sure that AT, or maybe it's the need for AT to be included in universal health coverage. So the overall grand challenge of a country might be, we want universal health coverage. Our job is to make sure AT is embedded into that, so that it will then just roll out naturally and it will just be embedded into a healthcare system. And then things like getting rid of import taxes and incentivizing innovation. Like, you could have specific government grants for AT innovation, for example, that would just catalyse things. And they could be linked to the Ministries of Health. So one of the most exciting conversations I'm having at the moment is with Rwanda, partly because the people we're talking to, I'm already speaking to the University of Rwanda, they're brilliant, that's brilliant. We already know all the NGOs, they're all brilliant. But the people who've contacted us is the ministries, and when you speak to them, it's 4 ministries, and they're all really excited. And they're saying, we want to support like some sort of accelerator, but for technologies that would then be adopted by the government and brought into mainstream. Now that's brilliant as far as I'm concerned, because we wouldn't do 48, we'd probably handpick 2 or 3, but then we'd work very closely with the Rwandan government to make sure it's fit for purpose for education, and they want to focus on education in Rwanda. And then you can also take deliberate and strategic approaches to scaling, so you can adapt then to local contexts. In terms of explaining AT, so investors need to know what they are, and that's investors can be an angel investor, it can be a venture capitalist, but it can be a company that wants to acquire a product, but it can also be a government, a healthcare system, it can also be UNICEF, it could be the ICRC. All these people in ways can be investors. So given the heterogeneity, so there's lots of different bits in there of the sector, this requires careful messaging so that the exciting opportunities such as robotics and AI do not overshadow the equally important need for prosthetics or walking aids. So I'm always in a constant battle of when people want to give us money to do a thing, they normally want, so I had a grant once for fuel cell technologies on wheelchairs. You know, I was given, I think, £200,000, and we developed the power chain mathematics of what you would need for fuel cells, and we demonstrated that a fuel cell could power a wheelchair rather than have what's commonly used, which is a standard lead-acid battery. And that's because there was a call for innovations in fuel cells. We needed some money to keep some postdocs, so we applied for that money, and we get it. Now, if I'd applied for research grants to look at how elderly people use their walking frames so they don't fall, nobody's going to fund it. Like, it's very, very hard it's just very hard to get people excited about, do you know how important it is to be able to independently stand and just get outside and be able to see some fresh air? It's so important to well-being and everything else. Yes, Captain. Oh, fuel cells, oh yes, here's £200,000, right? So I struggle with it as well. Every now and then I've had shared control of wheelchairs we've done. I do these big tech grants, probably one every couple of years, because I do need to, I also just need to have the publication record within computer science, right? Even though I know they're probably not going anywhere. I do quite enjoy them, but realistically, we're not going to tackle everything with AI and robotics. That we're just not. There's an awful lot of system stuff that needs to happen. So only when governments and investors understand the sector and the value of the sector will significant change be possible. In terms of open innovation, established companies should begin to better engage with startups, universities, other actors in the innovation ecosystem to drive innovation and growth. I mean, in India, you've got a very good CSR, isn't it, system. So the big companies are engaging through that. In other countries, you don't have that. There's no mandate for that. So you have companies that are very isolated. They don't even publish patents. They don't publish any of their papers, any of the innovation that happens inside them. And they are completely disconnected to the incubation lab that's just around the corner. And so we're looking for agencies and sector bodies. We need people to unlock that innovation. So governments and sectors can come in and help unlock that with certain incentives. So maybe some of the companies in India would have given away that money anyway. Probably not all of them. Does that make sense? So once the law came in, they had to begin to think about how they would do it. And then in terms of system strengthening, the link between market characteristics and the systems level of AT provision demonstrates the need for strengthening at each level. Like you can see that there's innovation patches in each bit, but there's not this holistic whole. Understanding the market characteristics of a sector is key to being able to diagnose what type of support is best needed. So sometimes it might not be a product, maybe it's a financing, like maybe unlocking the financing. There's a really great guy called Brian who's, he has a startup called, why have I blanked? Hope Tech Plus. So he first came into the accelerator, I think it was our first cohort or second cohort in Kenya. Brian Mwanda was his name, and he initially wanted to do a smart white cane. And he immediately went out and spoke to blind people, and then he realised the smart white cane's a really stupid idea. People have done it before, and actually they still have problems. So smart white canes can't see above. They can't tell you what type of product, type of thing is coming towards you. So he decided that what he's gone on to invent is. I was really lucky. I got to see it the other day. Actually, I was invited to the Royal Academy of Engineering for the grand launch in the UK. But they have a vest which has developed a new haptic technology. So it uses a standard pair of glasses with a camera, and it can tell you the types, but also the distance, and you can begin to understand the environment. Now, as he developed that technology, he realised there's no way he can bring that product to market in Kenya. Like the price point, he can't get the price point down, and actually people don't yet have white canes, so that they don't have the sort of basic training that you would then need to learn this haptic training. So what he's done is he's fundraising at the moment for a couple of million. I think he's got $500,000. He's scaling up. And he's launching in Austria and in the UK, that product. And at the same time, because he really does care about Kenya and innovation in Kenya, Hope Tech Plus has two new sort of entities in Kenya. One is called Sensors Lab, where he's created a space that's really lovely. It's a little bit like your space, but predominantly focused more on blind and partially sighted people, but for co-design. And he's got little incubation spaces, and he's basically running it as a not-for-profit for anybody that wants to try and test or drive user-based innovation in Kenya. You can apply, and at the moment he's just giving the desk space away for free because he managed to get $100,000 of initial investment, so he could run it for 2 years before people would start having to pay, so he could begin to get the pipeline in there. And then secondly, he started a little distribution company. So he started a distribution company of the available assistive technologies and making them more visible through the NGOs to how people could get hold of them. So he's now actually gone from one product idea to realising in this market space, my actual engineering stuff isn't going to work, but I'd love to be able to eventually bring it back to Kenya. How do I do that? Well, the entire distribution network needs to change. How do I do distribution network change? I help distribute AT better, get that strengthened whilst I'm growing the tech. What else would be great is if there was more innovation in this space, because then we'd have more ability to drive that distribution. So he sees competitors coming into the space as a positive to getting his venture back in there, because the more innovation, the more Kenya can be seen as an innovator in this space, the more there will be money and investment flowing, and the easier it will be to get out there. So he really took a long time to understand both the market characteristics of the sector, and then he really diagnosed what support he could provide in that country whilst also wanting to develop his technology somewhere else. Overall, better data is needed, and that's why we started developing, which I'll show you in a little minute, this tool for screening. Because if we knew how many people needed assistive technology in a country, then you could begin to scale the services accordingly. And initiatives at all levels must include active engagement of end users. So anything that's designed without users is always a bad service. So if you're designing for disabled people, you need 80 users in there. And in terms of finance and expertise, there's a need for investment to help scale viable solutions, which are currently stuck at a meso level. So they're stuck at that country level or just provider level. I don't know, but I'm sure I've seen innovators where they're able to scale to 20 or 100 products, but maybe only in a region, like a state, for example, of India, or they've got just half of India, but they can't get to the north of India, for example, right? So how do we help accelerate things that at that meso go internationally? Supply chains vary with scale, and that's another big problem that people have, and even just having the capital investment. So one of the initiatives that's being worked up at the moment, which, we're fringe involvement in, but at scale will probably lead, is some sort of, I've forgotten what they've called it, bridging finance. So effectively, once you want to scale, you need a loan to be able to buy the stock, right? And a lot of, and also if you provide to a country, especially in Africa, or any really low middle income country, the problem is that they might take months to pay you. Working capital, that's the word I was looking for, thank you. So they've got this working capital idea. And my only worry about that is that working capital, so if I give you $500,000 working capital, and you're the Indian government, let's not do India, you're the different country government, right? And you're an innovator in that country, and all of a sudden you're a distributor innovator, and I give you $500,000 so that you can buy products off, and supply for the whole country. But once you'll know they've got that grant. So I don't think you're going to be quicker at giving them money. Do you know? So I think, so that's the bit we're trying to figure out at the moment, is how do you make sure the country is locked into still paying at the same time? Otherwise it just elongates the problem. But working capital is a real problem to scale. And you need somebody to give you that working capital. And oftentimes banks don't like you at this point. They don't like you yet. You haven't got enough years of trading accounts. Innovating in just the general systems. And as I mentioned to you, there was a gentleman that really didn't like my presentation once on digital manufacturing systems. But luckily for me, he managed to cause such a fuss that the next day when I walked into that conference, the president of ISPO came to find me, Claude, and it's thousands of people at this conference. And this man comes up to me, and I've only ever, he's one of those people you've only ever seen on the massive stage. I don't know who he is, really. He's like, you are Catherine? Yes, I'm Catherine. You have upset many people. Like, yes, I have. Yes, I think I have, yes. And actually that night, when I finally got back to my hotel room, because I was in Japan, the time zone difference meant, although it was 10 p.m. my time, in Geneva it was quite early, still early afternoon. And you probably know, do you know Chapal Knapsis? Yeah. So I texted Chapal, I was like, Chapal, because he was meant to present with me, but he was sick, very ill actually, and so he wasn't able to travel, so I had to do it by myself. So I texted him going, I don't know what I've done wrong, but like, there's something really wrong. So he rang me and he said, oh no, it's perfect, you've upset everybody, that's good. And I was like, okay. He said, yeah, the first time I went to ISPO, everyone shouted at me. It's the start of a good career, don't worry about it. They don't like change. They'll hate you for a couple of years until they like you. Don't just accept that everybody's going to hate you for a bit and you're okay. So, okay, thanks, you didn't tell me that before though. Anyway, I hung up. But luckily for me, Claude said to me, well, what did you do? And I said, well, this is what I think I said. I can show you the PowerPoint. I don't know if it was recorded. He went, okay, well, that sounds not very controversial. So he said, why don't we meet at 5 p.m. at the end of the conference, and I will talk to some people and try and find out what the real problem is. So we meet at 5 p.m. and he said, well, I've spoken to about 50 people and I've heard 50 different stories, and I think they all link back to 1 to 2 people who are always angry, and I think they've just taken some things of what you said and they've decided a different slight version, and that's amplified, and you're new, so you're an easy target. He said, but the problem is we don't, you talk about digital manufacturing, and I said, yeah, maybe I should have been more careful in my talking about it. And he said, yes and no. Yes, because people are very resistant. No, because somebody has to talk about it, yes and no. And so from that, ISPO and GDI Hub joined forces, and we worked for a year on trying to understand. We did a systematic review that was led by Ben Oldfield. I forgot to write that on here, so I'll just quickly write it. Look, Ben Oldfield. So it was led by him, and we did a systematic review where we had experts in every continent alongside us reviewing what the literature says around innovation in manufacturing for prosthetics. So the reason we focused on digital manufacturing is this isn't prosthetics, it's wheelchairs, but we were already beginning to see 3D printed componentry enter into prototypes within both the prosthetics and the wheelchair space. So then we thought, okay, what is it I did? I thought I put his name on it. I thought I kept the slides the same. So we went into this project with ISPO through 80-2030 of what is the state of evidence for digital fabrication of P&O. So like trying to get over, do you remember when I showed you that the interview questions and that disruptive innovation, there was this problem that they kept saying there wasn't enough data and evidence. The prosthetist said that the barrier was there's not enough data and evidence. So we wanted to see, is that true? So this was the team from around the world. And the overview, well, the general scope was, we took a long time to decide the scope, but external devices, upper limb, lower limb, thoracic, lumbar, cervical, cranial, excluding dental and facial. There's an awful lot of literature on dental and facial, but that really was separate from what we wanted to do. We wanted to look at only things that looked at either a complete or a partially digital fabrication workflow for the P&O, for the prosthetic and orthotic components. Ones that tested methodologies across studies and components, or repair, augmentation, replication of devices using digital methods, or substantial discussion of digital fabrication within the article. So things where there was a real digital manufacturing workflow. And so what we found was that a lot of papers used qualitative methodologies. So when they did a new product or service, so I thought there was one other slide there, where if you think about, say, prosthetics, you can have digital in scanning, you can have digital in the fabrication, but you could also have maybe digital in the fitting, for example, right? So there's 3 different places where digital could come up. Now, all of these things, the orange is lower limb. So here we have lower limb, 73. Here we have, these are orthoses, lower limb. These are prosthetics, lower limb, orthosis, upper limb, the upper limb, and prosthesis, upper limb, right? So you have overall most qualitative, in terms of asking any sort of patients, there was none. They just didn't ask any qualitative data. So there were lots of studies where they put devices on people, or they worked with clinicians, but they didn't do any interviews, they didn't get any qualitative studies. So nearly all of it was none. Sometimes on patients, it was greater than 7 days. So they had, for studies that was greater than 7 days, there was a little bit. For patient studies which were on patients for less than 7 days, again, there was a little bit of qualitative. For on patient with no time indications, normally that means you fit it at a clinic, they stand up, they walk about, they sit back down again. Off patient meant you're just showing somebody something. But the qualitative methodologies were sort of, well, there was much more that didn't do anything than did something. Whereas on quantitative methodologies, we began to see a lot more done, like a lot more evidence of quantitative done. Then we also wanted to see around the technology readiness levels. So what level, so you know the TRL levels, yeah? You know these TRL levels? So basically looking at, these are the NASA ones adapted for assistive technology. So that research concept, proof of concept, minimum viable product, and commercial product. And this is, I think, the most interesting, let me just check the next slide. Yeah, these are the most interesting slides in my opinion. We don't get any formal evidence for things that are maturing. So once you get here, so like we get a little bit of evidence testing at TRL level 1. We get a bit more at TRL level 2, and you'd expect that, because at TRL level 1, you've just got a concept. Like, it's not a lot to test. And at TRL level 2, you've got components and bits, so you wouldn't expect that much testing. And you would expect a lot of testing at TRL level 3 and 4, because that's where you've got a proper proof of concept, and you're testing it. And then there's a drop, a massive drop, to TRL level 5. And then there's nothing at TRL level 6. So when that person was shouting at me, in the lobby of a hotel, he had a point. There is no evidence. And this is for prosthetics, lower limb, 3D CAD, lower limb, CAD CAM, lower limb other, 3D printing of upper limb, 3D CAD CAM of upper limb and upper limb of other. Orthotics, they're a bit better at doing studies a bit later. So in the beginning, you can see these are a little bit higher. It's a little bit more like a normal distribution. But still, you don't want that to be there. You want it to be up here. You want those levels of testing to be getting bigger. Like if I was back in Medtronic doing angioplasty catheters, here I might be testing 100 balloons in a lab on a day. Here I might be running a week of testing. Here I might be actually going into a month of testing. Here actually might be where it drops because I might be doing animal trials, which we know we don't like, but there might be animal trials. But at some point there needs to be more testing, right? You need more testing, more evidence. Also the number of participants in orthotics, you find that a lot of the studies just have one person. 11 to 30 also is quite high, but we certainly don't get very large numbers. Like there aren't large number studies, and that's partly due to the populations all being different, but still you can see why prosthetists and orthoticists are not convinced about these digital manufacturing systems because they haven't got the evidence base. In prosthetics it's even worse. Like most studies have no patients, even though they create a 3D printed prosthetic and they're trying to get prosthetists to engage with it. You could argue that maybe, because we don't have the why in this study, but you could argue that maybe because there's so much resistance, it's hard for those engineers to actually get somebody to try it, because they can't try it without a prosthetist. But that also shows, if you think about innovation, if you'd started the innovation with the healthcare providers at the beginning and with prosthetic users saying they want this, then together you'd be able to overcome those challenges a lot more. This graph is everything in one place, but looking at digital like different workflows, trying to look at the different workflows that take place. So for example, you might have CAD CAM down the bottom, then you've got something like physio CAD CAM, so you've got physio, then you've got CAD CAM, then you've got something else. So trying to see where the human is and where the different things are. And physio CAD CAM, this one, has one of the biggest, that works the biggest. So you have clinician and technology working together. And so that's a hint for innovators as to what's working well. When you've got the clinician in the team and they're integrated into the workflow, there's more chance of the technology being tested at least. Yep, and there's different types of materials being used. If Ben was here, he could spend at least a year talking about these different materials because he loves each of them. But PLA and then unstated. The other thing is the amount of things that were unstated was quite high. Like 93 papers just didn't state what material they had used at all. And maybe they're trying to keep it secret. But even a family would have been nice, like a sort of a subset. There is, though, an increasing trend over time. So the good news is that we are beginning to see more and more studies coming online. So between 2017, say, and 2021, there's significantly more than before 2015. So overall, what are the barriers and gaps we're finding to consensus from the literature? There's strong evidence that some categories is available. So CAD-CAM insoles, for example, and spinal braces, they're working well. People seem to be happy with those workflows. But very little formal discussion on the training of personnel on the use of equipment. Very little research that focuses on modification or rectification practices. Very broad range of testing methodologies, with some devices lacking any standardized testing at all. And the number of new articles concerning digital fabrication of PO is rapidly accelerating, yet the conclusions are all over the place because everybody's using different methodologies, different testing strategies, and it's almost impossible then to compare between studies. The barriers are lack of long-term, large-scale studies. It's a massive problem. We don't have any, really. There's a high range of variance in the production workflows and the materials. There are very few studies found so far for mature technologies, so anything above TRL level 6. However, we know commercial systems are out there. So evidence does exist, right? So companies obviously know that they're insured against any risk, but it's such closed innovation space that they're not allowing it out there. So if you are innovating outside of those companies, we need to somehow get a system in place for those innovators to be able to get that critical mass of evidence. The numbers, outcomes of geographical spread and of the actual use of digital technologies is unclear. And so we did some quick highlights of a global survey, just try to find out, because the other thing was people could say to us, well, nobody does CAD-CAM, nobody does it. Like, people just say, oh. And then we're like, well, no, people do it. So we did find that 103 people did respond, and you can see they responded from across the globe. There are significant places missing. For example, in Africa, there's very few. In South America, there's very few. But mostly, CAD-CAM and additive manufacturing, or both, there's more people doing it than not doing it that answered the survey. Now, obviously, there's bias in the survey, because if you have a survey on digital manufacturing and you do it, you probably want to say that. But still, it does show that there are places that are doing this regularly, and therefore it is possible. A lot of it, if you look at the body part, they've got lower limb. Yeah, there's different. They're looking at the scanning of a body part, or a negative cast, or a positive mold, or a subsurface body part. There's some virtual rectification. What you'll see, though, is that scanning of a body part and that then virtual rectification with hands-on is really strong. So that gives the respect to the prosthetist that they should get, because that hands-on bit is where their skill is most necessary and probably can never be replicated, or won't be replicated as well. But what you're doing is saying, well, that's absolutely key. How do we build a digital service around what you're able to do? And there's various different manufacturing that was occurring. In prosthetics, same. You see the biggest green for body part and hands-on. So just using that technology to basically amplify the workflow. And if you thought about that co-design, do you remember a couple of days ago we did those co-design workflows? And there was one example I had on here. It was trying to do that workflow, trying to understand the workflow of somebody. If you were to do a co-design session with prosthetists and they were explaining their workflow and they were explaining all their pain points, and then you went to explain, oh, we've got a digital thing that can help you on this bit. Everyone's telling us this bit's a problem and we have something to solve, then they might be much more likely to adopt your technology. So yeah, that's it. Thank you to the research team. And it is the work, Ben led it all and he wrote the paper. The rest of us just reviewed papers and helped with some of the work. So I'll stop there. We'll have a bit break. Hopefully that was a lot on innovation strategies. But my hope is that you get an idea of just doing a product really isn't enough. Like, it won't go to market. And you'll have spent a lot of time and energy. And it can be quite disappointing for you as well. So, so yeah, thank you.